Got it. It's time for Oral Systemic Connections, the people and technologies leading the medical dental integration. I'm very honored tonight to have two special guests, Dr. Craig Bax and Tasha Kozlowski. I made you a doctor, Tasha. How about that? Okay. What we're going to talk about tonight is the BaleDoneen Method, a 10-year perspective. It's really hard for me to believe that I've been a patient for 10 years and that also Dr. Bax has been involved in the method for 10 years. Time flies. A little bit of background on Dr. Bax. He's the CEO of Cure Coach Inc., software and hardware to empower cure for chronic disease. And he's the chief medical executive of the Cure Center for Chronic Disease in Springfield, Illinois. So what we're going to talk about is basically root cause analysis. Now, in dentistry, this is extremely straightforward. Dental caries, periodontal disease, bacterial infection, we know what the bacteria are, but for some reason, tooth loss is acceptable in society and it's accepted within dentistry. So we really are not a root cause profession. And the problem is in medicine, if you don't practice root cause, the risk is you're going to die prematurely. Okay, it's a different deal. So the fastest growing segment in medicine today is functional medicine, all kinds of different things. And so root cause analysis is the very basis of this. It's the basis of the BaleDoneen Method, which has been around for at least 15 years. I'm going to ask Dr. Bax, it might be 20 years. So Dr. Bale and Dr. Doneen were onto this very early. Here's the problem, very straightforward. Atherosclerosis, most common cause of death and disability, heart attack, stroke, dementia, the big three, right? But one of the underlying causes, and one of the reasons why I wanted to kind of lead this tonight is because I'm a patient and I want to show everybody my transformation, so to speak, my gaining knowledge. Okay, this has been a journey for me because I didn't understand any of this and I've kind of zigged and zagged. And I now understand insulin resistance, metabolic syndrome. I've had that like forever, right? And so it's the most commonly overlooked root cause of heart attack, stroke, and dementia. And as we know, carbohydrates and carbohydrate metabolism drives oral microbiome dysbiosis, okay? So it's all the same thing. I mean, when you talk about root causes, there's a tremendous amount of commonality. So I put this slide up. Any of you follow college sports know that Coach Leach died of a heart attack suddenly before Christmas. And I followed him on social media. Guy's wicked smart, really funny. This was a big loss. And anytime one of these high profile people have a heart attack unexpectedly, I always ask myself the same question. What was his medical care? Okay, who did he go to, right? So was he involved with a reactive doctor who he just went for regular checkups? I doubt if he was involved in a proactive program because things like that don't tend to happen to people in proactive medicine. And that's what we're talking about tonight. This is an interesting story. Dr. Bax and myself went to the preceptorship at the exact same time, and we didn't know each other until about 3 or 4 years ago. So everybody knows my story and kind of that pivot, but I would like Dr. Bax. So he was like on the dark side, and then he came to the light. And
go outside and he'll feed you.
So what I'd like to do is tell that story. What caused you to do that?
Well, thanks, Tom, and thanks for hosting this event, this webinar this evening, so we can share our joint perspective on cardiovascular disease. Excuse me. When you know it, I get a frog in my throat right at the moment I'm asked to speak. So I discovered, that I have arterial disease via a right intimate media thickness ultrasound in 2012. It's no surprise my dad had cardiovascular disease, my mother's diabetes. She had a number of strokes by then due to atrial fibrillation. And when I had a CIMT at a lipid meeting, my next question was, well, what else should I be doing? And I learned from the host of the CIMT that the BaleDoneen method was where I would learn that. And I was skeptical because of the concept of guaranteeing that those who follow the program could guarantee that they wouldn't have a heart attack or a stroke.
Right.
But when I saw what I saw, I couldn't unsee it. I learned that it was time for me to become. I didn't completely stop being an allopathic doctor. I'm board certified in internal medicine. That's how I was trained. It's hard to turn 180 degrees.
Yeah.
But I became an open-minded allopath and understood that there was much more that I could be doing, not only for myself, but then also for the patients that I was seeing with cardiovascular disease and type 2 diabetes and taking more and more medications. And so, and then to understand the role that another inflammatory process happening in the mouth of all places, which we completely ignore in mainstream medicine, in medical school, that's for you guys in the dental fields to be taken care of. And it's, it's like we're disconnected from one another. To learn that periodontal disease and endodontic disease was a major driver of these the end stage of a chronic inflammatory process called atherosclerosis. And so it was inspiring to me to hear the story. It was encouraging to me to learn that I could do more for myself. And it was motivating to me to learn that I could actually do this for my patients and actually reinvent my practice from one of reactive to and with a lot of chaos. And there's a lot of chaos in reactive medicine. You never know where your next phone call is coming from. All times of day and night when things occur. But being the scheduled proactive opportunity to structure a practice that was bringing people better health, younger arteries, and make a better life for myself as well. So that at 67, I'm looking forward to continuing to practice and be a happy doctor, much happier than I was prior to learning this.
Awesome. So I had the same reaction that you had, because when I saw Dr. Bale speak in 2013, and he said, I have 100% money back guarantee. If you have a heart attack, I'll give you your money back. That really turned me off, but it also intrigued me. And then when I kind of did my deep dive, I said, hey, what's it going to hurt? I'm just going to go through the process and find out. So this is the inflammatory, the BaleDoneen inflammatory tree. And what I like about the method is that it's very straightforward. And for me, this is the way I learn. It has to be kind of simple, right? You can lose me pretty quickly. And so here's a tree of inflammation, and here are root causes. So this is the basis for the guarantee. And Dr. Bax, correct me if I've ever say something incorrect, but this is my understanding. If you extinguish all of these root causes and everything is negative and you don't have any of these root causes, that's the basis of the guarantee. Because what Dr. Bale says is these are the risk factors. If you extinguish the risk, it's impossible to have a heart attack or stroke if you don't have periodontal disease, endodontic disease, hyperlipidemia, all of these root causes. So the next slide here, this is from one of your presentations. I'm going to have you kind of pick and choose some of these and kind of explain, the ones that you think are the most important or are the most significant. So this whole concept of root causes, I come to you as a new patient, you drill down into each one of these things and kind of make an assessment and make a treatment recommendation. So kind of walk through this a little bit for me.
Well, I'm a firm believer in that keeping it as simple as possible, at least at first. It's easier to get the patient to buy in, and it's easier for them to understand. And it's not as daunting as saying you're going to need to address these 18 or 20 or more issues all at one time.
Right.
So, pretty much everybody knows what their cholesterol level is. It's been a major source of attention for many, many decades. And pretty much everybody knows hypertension and what their blood pressure runs and how important that is. Smoking, of course, and type 2 diabetes. But that's really looking at the problem far too far down the line. And they understand the concept of insulin resistance and what drives it, I think, is really, really key. So one of the things that struck me about the initial preceptorship is this was kind of like a later reveal, this whole issue. And if you look at the Beat the Heart Attack Gene book, it's a later chapter about insulin resistance. It's the number one driver of chronic disease.
Yeah.
And I think it's important to understand why it's so prevalent. Many of you may have seen a 60 Minutes program a couple weeks ago where, there's this overweight woman is trying to convince us
Can you
that,
speak louder? I know, I'm trying.
I think it would be helpful if everybody else mutes themselves.
Okay, view options.
Can you,
Не могу слышать ничего. Okay.
Right.
Что-то не... Мы выключим.
It's hard to talk over people.
yeah,
So,
there we go.
but the point is that as human beings, we're perfectly adapted to a nomadic hunter-gatherer lifestyle. We aren't adapted or created to live in a grazing environment, and yet that's the food environment that we find ourselves in. And so we have to hack our genetics back to our hunter-gatherer roots and avoid the sweets and the starches and the snacks and the sitting. And I came up with the top four S's that we address right away. And pretty much everybody's aware of salt and smoking and stress. Maybe not, maybe sleep is a novel idea to many people, but the idea is that we bring those lifestyle factors in very quickly. And then introduce to the patients that, your dentist and particularly your hygienist, no offense to the dentist, but the hygienists are really the key linchpin in making that connection. If you have endodontic, but particularly periodontal disease, even if it's microscopic, undetectable to the naked eye, you need to know that. You need to address it because it works in concert with these other metabolic conditions. The role of vitamin D, never been more important than ever with COVID, and the role of vitamin D, not only in modulating the immune system. Low vitamin D levels lead to hyperactive immune systems and cytokine storm, but it also plays a big role in mitigating the effects of insulin resistance. And then, the genetics and the home, we can go into these in more detail. The genetics gets a lot of attention. There's only a couple that I think are really, truly actionable. And the others may add a lot of information and noise, but I think focusing so much on genetics makes us think, well, we're just kind of stuck. This is our fate. Well, in fact, the point of genetics is epigenetics. How do you understand how your genetics influence how you respond to certain medications and what approach is right for you, and even what kind of diet is more appropriate for you? So it's really important that this all be evaluated. The list, kind of like a checklist, like a pilot goes through before they take off for safety and for getting from point A to point B without a crash. It's important that we cover all these things, but in some patients, the top of the list is more important. Others, you need to personalize it so that other issues come to the forefront. So that's hopefully as I try to make it as succinct as possible.
Right. No, awesome. Okay, so here's where we start. This is part of the diagnostic part, the CIMT, which is the carotid ultrasound. I'm going to have you talk a little bit about this, and then later I'm going to talk about what you're doing to kind of innovate this a little bit. So talk about the ultrasound.
So the CIMT, of course, stands for carotid intima media thickness ultrasound, which is it's very important to understand that this is not your basic standard hospital available duplex ultrasound that you can get anywhere. It's a value. That ultrasound is only of value to the vascular surgeon because it identifies patients who are currently candidates for surgery, which obviously is a terrible approach. It's like waiting for stage 4 cancer to appear and then suddenly decide you got to cut it out. So the CIMT actually measures the inflammation in the wall of the artery in a standardized fashion. And of course, the benefits with ultrasound is non-invasive, absolutely harmless. It's used to image infants or babies in utero, but it provides a measurement baseline. The challenge is that it's only really available from a couple of vendors in any meaningful, reliable way around the country, and they send the sonographer out to you. But the logistics and the economics of arranging this is you have to convince your patients to schedule on a certain day, and so it can be a bit of a challenge to get that done. And so I went kind of searching for another alternative to, at least for the first step in trying to identify, do you in fact have arterial disease or not?
Right. Yeah, and we're going to talk about that in just a minute. Okay, so talk about these. These are some images that kind of discuss in a little bit more detail plaque formation and the kind of things that you may find in a CIMT examination result. Okay, talk about that.
So thanks, of course. So there are two factors that really are that we focused on with the CIMT is the amount and the type of plaque, and then the thickness of the wall of the artery. So I'll talk about the amount and type of plaque first. The plaque is location is actually not that important. It's the total overall amount of plaque that really matters. And think of plaque like a pimple. I'm sorry, maybe it's a gross example, but or like a boil in your skin. It flares up, it's very active, inflamed. That's when it's prone to rupture and lead to an event, which is what you see at the right side of that arterial schematic that Tom has at the bottom of the page. And it's plaque rupture that leads to the formation of a blood clot that occludes the lumen of the artery. In the case of the carotid artery, it leads to a stroke. In the case of the coronary arteries, it leads to a heart attack. Well, you know what? You don't want to wait because that's a very sudden, as the names imply, attack, stroke. You know, it's sitting there under the surface like a ticking time bomb, literally for decades, and then suddenly you're in a life-threatening or a life-altering situation. So the idea is that plaque forms much like a pimple or a boil, and then over time it becomes heterogeneous. I call it healing, and then the end stage of plaque is the calcified or healed or scarred state. And that's why it's very important. If we have time, we can talk about coronary calcium scores and how unreliable they are for following disease. But the thicker the wall of the artery, the thicker the wall of the artery, the more inflamed. And the idea is that we want to see our arteries get artery wall. That's where all the action is. It's in the wall of the artery, not in the lumen, at least in the early stages leading up to an event. And that by modifying the disease process in the wall, by getting it to settle down, it's like getting your sunburn to settle down and heal. That's what this whole endeavor is about.
So these are some terms that I have learned. This is an illustration. This is not a result from my exam. The bottom figures are a result of my exam, but this is just an illustration. So basically what happens when we talk about the pimple, so to speak, the plaque that is soft, that's the most dangerous plaque. And then over time, you have a transformation to heterogeneous, and then echogenic is the calcified, more stable plaque. So your risk, as you go through this transformation with the method, that lessens your risk. So down here, I had a right bulb 2.0 soft that went to 1.3 echogenic, and the left bulb 1.8 soft to 1.4 echogenic. That is the reversal of heart disease, correct? That's the process of reversal, right?
Precisely. People ask me all the time, will the plaque go away? And I clarify that, well, the plaque doesn't really go away, but you can heal it.
Correct.
And that's your goal, is to heal and stabilize it. So the risk of rupture and event is virtually nil.
Okay. So I'm just going to go through some of these topics and we'll go through really quickly. Because I see a lot of things on social media, you know, this whole thing of what I call self-empowered medicine, and it's everywhere now. I mean, it's on Facebook Reels, TikTok. You've got all kinds of docs, you know, hawking all kinds of programs. And people know that our healthcare system is broken and they're looking for solutions, right? I mean, dentistry is kind of safe because it's not a DIY thing. You can't do your own dentistry, even though they've tried some orthodontics at home, hasn't worked out so good. So dentistry is safe, but there's a lot of conversation around lipids, okay? And so what I want to do is I want to walk through lipids, statins, all these things that are to a novice, they're a little bit confusing. Now, you know, I've been educated to kind of understand what this is. So, you know, let's talk about also when you do a panel, you're doing a little bit more of an advanced panel. Okay, this isn't your standard primary care panel. It might go just a little bit deeper. This panel might be kind of standard. So one of the things that I wanted to ask you about here, and I asked you offline about the triglycerides to HDL ratio. Okay, and first off, you can just kind of walk through here and talk about, you know, what are the things that concern you, and what are you know, just tell me what you look at a panel. What do you look at?
Well, it's actually interesting. Over time, I look at the lipid panel less and less to tell me about the lipids and more to tell me about what's going on with metabolic balance, particularly insulin resistance.
Nice.
So you mentioned the triglycerides to HDL ratio. Those of you who are familiar with the term metabolic syndrome, it's classic definition is 3 out of 5 of hypertension, low HDL, elevated triglycerides, waist circumference ratio, or waist over 40 centimeters for a male, over 35 centimeters, I'm sorry, inches for a male, 40 inches for a male, 35 inches for a female, and a fasting blood glucose over 100. But in reality, if you have any one of those 5, you're in trouble already.
Okay.
You know, in health, in medicine, we'd have a tendency to say, well, you got to prove to me that you have, you know, disease severe enough to treat with medicine or surgery. When in fact, we really should be saying, you know, let's find out when you stop being healthy and start, stopping this train before it gets too far down the tracks.
Right.
So bottom line is when you see elevated triglycerides or low HDL, think of insulin resistance, which is I call insulin resistance pre-diabetes.
Right.
So before you have type 2 diabetes, you're pre-diabetes and it's all defined based on your hemoglobin A1C, which is kind of an arbitrary, cutoffs. And then pre-diabetes is when your glucose is normal, but it's like keeping the car moving at a constant rate of speed, but left foot's on the brake, right foot's on the accelerator, and there's smoke out of the brakes and out of the engine. And I guarantee you wouldn't want to buy a car driven by somebody who drives a car that way. So the point is that the elevated triglycerides, low HDL really trumps elevated LDL in my assessment of the lipid profile.
Okay. Very good. Talk about fractionation. I had trouble with that word. Very few people get this test, in their routine work. And so basically what I got from your website was that larger LDL and HDL particles reduce the risk of arterial disease and events. Smaller LDL and HDL particles increase risk, right? So this is another level of testing that you ask for in an exam.
Yeah, and this is a rabbit hole that a lot of people go down. They think that there's a lot they can do to modify it, but in reality, it's another marker of the metabolic imbalance or metabolic syndrome. So I think of larger equals lower risk. They're LDL particles that stay in circulation. It's really about a size. The smaller, more dense LDL that you see, where that arrow points small LDLs, those are like armor-piercing bullets when it comes to getting trapped in the endothelium. They penetrate the wall of the artery. They're more readily oxidized and trapped. And so, not to get into too much detail, but the more smaller, it's called a pattern B. That's higher risk. That's more associated with the metabolic syndrome or insulin resistance and chronic inflammation. The larger LDLs, that's called a pattern A and is a lower risk. And I typically do it at the baseline, but I've learned over time that it's something that does not tend to change. It's largely you can blame your ancestors for which pattern you are for the most part. There are some, like niacin seems to cause a little bit of a shift in a favorable direction. I've seen some changes with bergamot, but by and large, other interventions don't seem to modify this all that much, unless the person really deals with their metabolic syndrome, which fundamentally means getting more lean, losing fat. Sorry, I had to say the F word, fat.
Okay. Insulin resistant diabetes. I think that's you've got a lot of nice terms, and I like this one. So when I get my test back, this is always the first one I go to because I have diabetes all through my family, sisters, father, grandparents, everybody, right? And so I always go here. And for 10 years, I've been bouncing around between 4.8 and 5 each time. And it's remarkable. I mean, I've been waiting to shift over. I'm not a fanatical patient. I'm an okay patient. I'm not your best patient, right? I love chocolate cake and I have to drink a Coke once a week, right? So I do have that sweetness, the desire. And
Too.
but anyway, so let's talk about this, because what I've learned is that this is really, where you need to be spending some time.
Well, so the fasting glucose, I always call that your pop quiz. Anybody can have a good or bad day, depending on what they had to eat the day before. But the hemoglobin A1C is like a semester grade. That's a 3-month average of your glucose levels before and after meals. And generally, if you're on 5 or under, you got a long way to go before you actually develop diabetes. However, you can still be, it's like the car can be moving, at a good rate of speed, but even if you have some light pressure on the brake while you're driving down the interstate highway at 60, 70 miles an hour, you're going to be causing some damage. That's your genetics that drives that. The fatter you get, the more insulin resistant you get. I'm sorry to say it that way. So by paying attention, okay, piece of cake or a Coke once a week, that's not the problem. It's this steady diet of highly processed, highly addictive foods that give our brains pleasure, like heroin and cocaine do. Yeah. But you can live without heroin or cocaine, but you can't live without food. So you have a culture that pushes Oreos at you, followed by a diabetes medicine like Ozempic, and then how to get your free diabetes testing and treatment supplies through your insurance program. We're just constantly bombarded to this, so we have to constantly avoid it. But I look at this and I say, you know what? Yeah, you could still be insulin resistant, but I'd say you got it under control.
Okay, let's talk about statins, because this is a great subject. You'll see all kinds of social media doctors, pluses, minuses, but what I've learned, and what I learned from you and from other people, tell me and I can't think of the word that you use, but statins have a dual purpose, one of them being anti-inflammatory, and not all statins, right? Talk about that for me.
So, 20, 30 years ago with statins, we always talked about, well, they're lipid lowering drugs, but then there's this mysterious, we call it pleiotropic effect.
Pleiotropic.
For a long time, it's like this kind of mysterious, there's something happening besides that, but that's kind of interesting, but we're not going to talk about that. Well, and this is what Brad and Amy through the BaleDoneen Method put a name on that. It's anti-inflammatory. They're first and foremost effective at preventing heart attacks and strokes because they affect inflammation. The LDL is kind of like a drug test to see if the patient's taking the statin or not. Now we have inflammatory markers, and I can tell you whether or not a person's taking their statin by following their LPPLA2. Well, if we may get to that as well.
Yes.
And their LDL. So the point, and so the reason people get into trouble with statins and have a lot of they use the wrong statin based on their genetics or its actual characteristics at too high a dose for the wrong reason. Drive down that LDL at all costs. Cardiologists, lipidologists, many of them are just like children running around with a hammer. Every problem looks like a nail, and they just hammer that LDL cholesterol, not realizing that atorvastatin might make your lipids look great, but it's not really anti-inflammatory enough to reduce your risk of heart attack or a stroke. So we use lower doses for the anti-inflammatory effect, using the right measurements. And you can. So if you go to my website, thecurecenter.life/statin, there's a whole page written about why there's a problem. And then this page, this title of this paper really brings up a big issue, and that is the definition of primary prevention. So this paper defines primary prevention as you haven't had a heart attack or a stroke, but you could have arterial disease or you could have pristine arteries. Dr. BaleDoneen divide primary into, they call it primary and secondary. Primary means no disease, no events, your arteries are pristine, no evidence of atherosclerosis. There's not too many of those people around, to be quite honest with you, in our society.
Right.
And you have those that are walking around with these ticking time bombs, this plaque, these pimples in the walls of their arteries. They haven't had an event, they're called primary prevention, but they have disease, and it's just waiting to come back up to bite them. So, it's important by imaging to know, does the patient have atherosclerotic disease or not? And so I use statins to treat atherosclerotic disease, not lipids. If you have pristine arteries, high lipids, we'll just watch it. But if you have sick arteries and great lipids, we're going to talk about medicine to deal with that, whether it's a statin or a statin substitute like Bergamot BPF.
Okay, that was a great lead-in to the inflammatory panel. So when you go to your reactive primary care, what you might get at best, you might get a CRP, right? And that's a minimal indicator. So kind of walk through these and tell me, what they tell you. Because one of the things I've learned, we've had to chase myeloperoxidase a little bit with me. I don't know, it varies a lot, but that has a lot of oral implications, right? If I'm understanding that correctly. But go ahead and walk through these.
Well, CRP, I have a love-hate relationship with C-reactive protein. Sometimes I get on a bent on a streak where I'll start ordering again because I get a lot of people asking about it. But it's like a fever or just kind of feeling bad. It's very non-specific. It doesn't point you in any particular direction for a source. I'm going to skip over LPPLA for a moment and go to the myeloperoxidase that you mentioned, and it has such an implication for oral health. Myeloperoxidase is the enzyme that turns pus green. So if you have a sinus infection or if you have a boil and you see this kind of nasty pus coming out of the lesion, that's myeloperoxidase. So but it also, it's like bleach. And when myeloperoxidase is circulating in your blood, it can cause it's like caustic. It's erosive of the endothelium. So it gives your arterial wall endothelium the equivalent of road rash. It's like scraping your knee. Well,
Gotcha.
that's a form of clot that can flip off and cause an obstruction. So this is one of the markers that we find, that we check every 3 to 6 months in our patients, just to see, okay, is there something occult? And I would say about a third of the time when I see an elevated myeloperoxidase, and I confirm it, and I send them to their dentist and say, look for an infected tooth. And about a third of the time that, the dentist goes, well, they're not symptomatic. Why would I look for that? Just look for it. And lo and behold, there's an apical abscess with,
Right.
but you got to look harder for it than just plain x-rays. It takes a CT to typically find it.
Right.
And the one caveat with myeloperoxidase, often it needs to be confirmed because it's a technically tricky test in the terms of the processing. So if somebody's going along fine, they feel fine, and they suddenly see a jump, I'll generally repeat it within a week or two just to make sure that it's real. But if it's real, then you need to be looking for this pocket of pus sitting somewhere in their body. And the mouth is a classic example where it can just sit there doing its thing without causing any symptoms. And why is that important? Because that inflammatory process here can be setting you up for an event, a stroke or a heart attack.
Okay. Any other of these you want to comment on?
Microalbumin creatinine ratio, that one, it tells us about the health of the endothelium. The 1 cell thick layer, that actually it's also a very sensitive indicator of early inflammatory disease. And the LPPLA2 tends to tell us about the endothelial matrix and how inflamed it is. So they each kind of can have a different contributory element to overall sensitive inflammation. And the bottom line is you want to have a program that diminishes all these as much as possible. And it's lifestyle, it's vitamin D, it's supplements, it's using anti-inflammatory medications like statins, and putting it all together. Much of what I do, I like to think of, as kind of putting together a program to treat a cancer. You have your radiation, chemotherapy, nutrition, maybe immunotherapy. It's all putting all these things together into a program that's personalized to address that particular particular tumor.
Okay. And once again, a lot of these slides that I put there were based on things that I had to learn in my confusion. Okay. So I told you the story about how, the first time I had a calcium score 10 or 15 years ago, it was like 0. And then I get in the BaleDoneen method and my calcium score just like goes up. And I was like, what the hell's going on? Right. But once again, I'm not understanding. And I think a lot of people, I think there's some docs that don't understand this, that the calcium score, well, let's go back to the CIMT. It's not looking for soft plaque. It's not identifying the soft plaque. The calcium score is actually identifying probably more of the echogenic, am I telling that correctly?
Yep.
And so that could be a good thing, and increase to a degree. If the calcium score is increasing, could be a good thing. So it's kind of counterintuitive, and it confused me forever, right? So talk to me about coronary calcium scores, because there may be people in the audience that say, I've had this done, or I want to go get this done.
Well, I'm trying to illustrate it this way. I mean, you're a good example. You said you had echogenic plaque. I'm sorry, you had soft plaque that became echogenic. And in the process of becoming echogenic, the thing that creates the echoes on ultrasound is calcium, and to some extent fibrous material. So what you're showing is that calcium score, the same plaque is there, but it's just going from soft to heterogeneous to calcified, and your calcium score is going up because you're on treatment. You're under anti-inflammatory treatment. You're following your lifestyle changes, and that's actually a good thing. Now, if you're just going along untreated and you have a coronary calcium score and you're following that along and your score is going up, that means most likely you're accumulating more and more and more plaque of the same kind, soft to heterogeneous, but it's accumulating, and sooner or later, one of those plaques is going to rupture and occlude your coronary artery, and then you get the widowmaker event, and hopefully you have an AED and somebody with no CPR and somebody who can get you to the cath lab, in minutes when seconds count, quite frankly. So,
Very good.
I
Okay.
use that expression very commonly: a fool with a tool is still a fool. If you don't know what the tool actually does and you use it the wrong way, you're gonna get the wrong answer and the wrong recommendation.
Okay, so let me talk a little bit about the dental side of this. This is something that at our next meeting, I'm going to kind of be unveiling. It's something that Tasha and I have been kind of working on. And this is a result of, what Dr. Bale taught me initially, because in order to become a patient, he wanted a biofilm DNA test. He wanted a sleep screening and a CT scan looking for those endodontic lesions, right? So in your work as a BaleDoneen physician, these are 3 contributors to that inflammatory root cause deal, right? It's part of your analysis, especially when you do your initial blood work. Your job is to go find out what's making those labs incorrect and correct them, right? So the dentist, and that's why I've said from the beginning that Dr. Bale is dentistry's best friend, because he can't practice and you can't practice without a dentist. And so Tasha and I have talked at length about the fact that no one's ever like created a directory of people, because what Tasha and I are doing in our training is we're training people in these disciplines, right? So why not we create a directory so that someone like yourself can find a like-minded dentist, and this information can be exchanged in a HIPAA secure portal. And I know you've got a portal with your model we can talk about in a bit, but this is what the dentist contributes to the whole conversation of functional medicine. It doesn't have to be necessarily a BaleDoneen physician. It's anybody that's looking at the complete root cause. They cannot, and they cannot ignore dentistry, because there's too many times that you've come to an impasse and the only thing left is got to be in the mouth, right? So we're going to be talking about this. This is one of the cool things we're going to be unveiling at our next course, which we'll talk about a little bit later. Okay, so I want to talk about self-empowered healthcare, biohacking, and social media. Okay, so our healthcare system is broken, busted, ruined, right? And so we live in a time now where we get information everywhere, and there is a desire, and I've been talking about this for probably a decade. There is a desire. I tell the dentist, people want to take an active role in their health, both dentally and medically. The dentists aren't quite convinced that they want to take this role that that Tasha and I are working so hard to train people on. But believe me, you don't have to go anywhere now on the internet and see that people are signing up. So I just took a few screenshots, and we've talked about this online. So here's a place where you can go. It's like a car wash. Get the ultimate, get the 2 ultimate plans plus, enter age, blood results, genetic testing, 700,000 SNPs. And then here's Gundry, and I've seen Dr. Gundry, and I like Dr. Gundry and I like Mark Hyman, but both of them are saying do not use mouth rinses. Okay. That's such a generalized statement, and it's so dangerous, because the basis of this whole periodontal disease from the beginning, which I've started this whole training and coaching, is about we need to use antimicrobials. And this goes back 30 years to Dr. Kai's. He brought what's called anti-infective treatment to dentistry. The reason why we have so much disease is we use things that aren't antimicrobial. So this is all misinformation. It's all very dangerous. And it just amazes me This is one that we talked about. Now you use the word artificial intelligence on anything. It's kind of like years ago when you use the term laser. Okay, laser meant modern. So if you're a dentist and you're a laser dentist and you're a laser hygienist, you're like modern. Well, the new term is AI. Okay. And so the opposite of AI is genuine intelligence. Okay. You have artificial and genuine. Well, I kind of want to stick with genuine. Old guys like you and me, right? We're like genuinely intelligent. We talked about this. Here's a coronary angiogram that's read by AI. And you and I talked about this, that this could lead to, and this is a whole body MRI. And we talked about, you do whole body MRIs and you're going to find artifacts. Okay. You're going to go on a wild goose chase. And this could also lead to, not an event, this could lead to a procedure, right? Because, so talk a little bit about some of these things.
Well, anytime I really have a concern about these fishing expeditions that are being sold to patients, and that literally is the word. It's all being sold, and I think a lot of it is simply opportunistic, and it's not about really helping people. It's giving them information, but is it really giving them guidance or wisdom? I can go on YouTube and I can watch some videos about how to build a deck, but you wouldn't want me to build a deck for you, because I have some limited skills. But if you put me under the coaching of an experienced deck builder, I can contribute to it being, coming out okay. But the same thing is true with all these technologies. Their activity, and people think because they're spending a lot of money that they're getting a lot of value. And in fact, you can get much more information for far less money without exposure to radiation and the cost, if you just know a few relatively simple things, paying attention to chronic inflammation, knowing if you have arterial disease based on an ultrasound. You don't need to know all this detail. I'm somewhat familiar with for instance, the AI coronary artery calcium scan or coronary artery scan. The AI helps to characterize plaque in the coronary arteries like you can't do with ultrasound, but $1,500 just to process the images. You have to get the images in advance, from the CT scanner. Is dye exposure involved? It's overkill. Now, some people want that executive level of treatment experience, and I want to, it's like I want to go spend a lot of money just to prove how important my health is. I think just be careful about these and understand they're selling you something,
Right.
And selling you an experience, and it isn't necessary. My whole purpose in taking what I learned at the BaleDoneen Method was to make it more accessible to more people, not just the upper crust, the people who don't have to ask how much.
Yeah, no, and you've done an outstanding job of this. I threw this slide in here because I thought it was interesting, and there's kind of a backstory in this, and I'll talk about this in my course. This was my first lecture, University of Kentucky, February 2009. And I was in the country's in a recession, and I'm talking about the niches and the different things. And so this was a slide that I had that said that the biological health-oriented practice is the largest emerging market opportunity in modern history. Now, that was based on a lot of things that require an explanation, but I get an email last week from Chris Phelps. A lot of my audience is going to know Chris. It says, why is holistic dentistry the fastest growing niche in dentistry? So I was just 14 years, early on this whole conversation, as far as like the wellness centered model and what it looks like. People are starting to look at this in dentistry. Okay. Now, one of the words that you've used, and I'm going to talk about what you're bringing to the table, something new, is now that I have your attention. So basically, one of the things that Tasha and I are doing is we're training people in how to screen biofilms with video microscopy. So you see these critters on the screen and it gets your attention, right? That's the first thing that happens. Is like the patient goes, oh my gosh, what is this? Well, this means that film on your teeth is alive, okay? And that's kind of the core on some of the courses that we teach. But this term is straight from your training, Dr. Bax, which caught me immediately, because this is what the microscope means to me. Now that I have your attention, it opens the door for a lot of conversations, okay? Now, this is what you're bringing to the proactive model, and it's something you've been working on for a couple of years, which I think is really cool. Okay, so this is a butterfly ultrasound. And this is a really, really sleek device, hooks right up to your iPhone. I'm gonna show you show the audience a live video in a moment. The quality of the images are amazing. So the concept is just like what I'm doing with the microscope, beginning the conversation, engaging the patients in a co-diagnostic process so that they can choose, they can make better choices, right? Well, you seem to have an infection. Now let's go ahead and do the biofilm DNA. Let's look for pathogens. Let's look at your health history. Let's put all these pieces together. So what you did, which is pretty cool, is you said, hey, what if we had a precursor to the CIMT, which is a couple $100 test. It's almost impossible to find anybody that does it. Then you have to schedule it and all this, that, and the other. What if we had a test that was like easy peasy, right? Minimal expense, and we can identify soft plaque, because once you have soft plaque, now we know the risk is there, right? And it's just like the microscope. Once you have a certain bacterial profile in your biofilm, the risk is there. I don't care if you're 20 years old or you're 60 years old, right? So what I'm going to do now is I'm going to show, this is you at our last event. And what you're doing is you're showing how absolutely, and I mean, I'm sitting here on my computer screen and I can see this vessel just as clear as day, right? And you have one hand on your phone and you're kind of talking out loud, and you've got your hand on the area of the carotid artery, and you're doing a preliminary scan on this patient. This is really, truthfully amazing. So what your goal is to get this in the hands of a dental hygienist. And I personally have not figured this out yet in the practice that I'm working, but I think it has merit as a preventive tool, because once this is identified, let me see on our next slide. So this lower image, this lower right here, I mean, anybody can see that soft plaque within that artery. That's a risk factor, right? Now, is that probably soft? You know, so I'm gonna let you comment on where did you get this idea to have a more preliminary level of screening before you get into like the CIMT? Where did that idea come from?
Honestly, I'm not exactly sure, but I felt that, well, there was discussion among at least one of the major vendors for CIMTs about training doctors to obtain the images to send to them in my own practice, because the constant frustration is, well, I think you should have this test. Well, can I get it done at my local hospital? No. Can I get it done now? No. When can I get it done? Well, I'm trying to put together a list of people. I'll let you know when I can get the stenographer here. And then all momentum stops, nothing happens. As opposed to, hey, you may have arterial disease. I can take a look at you right now. It's under $100. What do you say? Let's scan first and ask questions later. And the answer is, generally speaking, well, that doesn't sound too bad. And then so it takes about literally a couple of minutes to do the scan itself. Just to clarify, you mentioned if you find soft plaque, I would say you find plaque that has not erupted or has led to an event. Echogenic, it's going to be partially echogenic. Soft plaque is very tricky. Even with CIMT, sometimes you spend a lot of time looking at images. But the point is, you can identify a lot more people if it's available on the spot, and it can be done quickly. And so I've been through three. The butterfly is actually the third ultrasound of this type. They're all called point of care ultrasound, or POCUS, or pocket ultrasounds. I think the skeptics in the sonography world would call them toy ultrasounds. They're not intended to give you a great deal of detail like the CIMT. The analogy I use is like the pregnancy test. It doesn't tell you. It tells you you do or you don't, you are or you aren't, but it doesn't tell you what you're having, when you're having, and what are the things you need to be aware of for a safe outcome. So the idea is, okay, now that I can show you visually that you have this condition that you had no idea about before, talk about how to get rid of the risk associated with it. How do we heal it? And that is a conversation that is so much easier. Again, now that I have your attention, it's an attention gathering tool. And I would say in any practice, there's only so much time in every encounter, right? But I would say if you have time to do a hemoglobin A1C and you're doing blood pressure checks and you're doing other things that are kind of screening, this is really where the rubber hits the road. And if you can incorporate it routinely, and you have somebody, and the key thing with Butterfly, it's not just a device, it's a platform that allows Tasha could scan Tom, on the spot, and I can see the images immediately, and we're hundreds of miles apart. And we can use the hand-eye coordination, technical skills of a hygienist to obtain the images and the experience of someone who knows what they're looking at to feed back and give the patient a report in a relatively short period of time at a very low cost.
Yeah. So this is this column here where you're talking about this point of care on the spot, 5 to 10 minutes, qualitative, not quantitative, minimal training, non-radiologist, get it done that day. And once again, it's so similar. When I saw this, it's just so similar to what we're doing with a microscope. They're almost hand in glove. A picture's worth 1,000 words. Same thing with the microscope, the power of the video. Yeah, I mean, this just it just runs so parallel. Okay. So, coaching for better outcomes, once again, getting down here to this root causes, right? We're trying to prevent the emergencies, the stents and the surgery and the traditional things. Everybody knows that a stress test essentially clears you for that day, that you could have a heart attack tomorrow. Angiograms carry, procedure risk. Stents and surgery, once again, it's very reactive. So, we're both so like-minded in that we're trying to be proactive. Okay, so let's talk about the reactive model and where I think everybody here is interested. This is a primary care physician. Okay, I have a primary care physician that I see twice a year. Okay, he's kind of fascinated. I bring him my labs, and first off, he's totally blown away by the fact that I care. I think there's so many people that have given up on our healthcare system because it's such a failure, and it's such a failure in educating people that they're out there looking on the internet, right? But this is how I see it, and this is what can happen. The integrated model, where you do have the primary care physician, you have the dentist, and then someone like yourself that is a preventive expert on the outside. So this is, I go to the primary care, I go to the dentist, and I go to you. So all of these people need to kind of be in concert, okay, sharing information and working together. And I think with your Cure Coach app, okay, that's another piece of technology that you've developed to enhance that experience. So I think COVID kind of pushed you maybe a little bit further forward into your virtual model, where I see you on Zoom, you order the labs through your app, and I just go to Quest here locally, and then that stuff gets to you, and we do our thing, right? So maybe that was, I call those the blessings of COVID. Maybe the concept of remote. So like anybody who's in this audience, if they wanted to become a patient, they can still have their primary care doc and still see you in managing this integrated model, right? So this is a work in progress. That's really a lot of the end game of our course that we're doing. It's very hygiene centric, because to me, that's where the education is going to take place. That's where the tools for the successful treatment of inflammation are going to take place, is in hygiene. That's why it's there. Okay. So, and here's our course. I got to pitch our course. March 31st, April 1st in Lexington. oralsystemicmastery.com is all the information about that. And Dr. Bax is going to be there if you want to, and he will do a carotid ultrasound, a screening at no additional cost. It's included in the cost of the course. Meet him. We're going to talk about this at more length. And here are contacts information if you want to take a quick picture of that. Cell phones, websites, thecurecoach.com, thecurecenter.life. And I think most people know how to track me down. So what I would like to do is I want to take any questions because I think we should have some questions around this presentation. So should we put them in, Tasha, in the chat? Is that would be the best place to kind of go into the chat? And you got some things to put in there? Or if anybody wants to unmute and ask a question,
Yeah,
I
if I
guess.
just want to unmute. I've been trying to just keep everyone muted just so we didn't have any background noise, but
Yeah.
Nothing in the chat right now, so I say just chime on in.
Yeah, somebody just unmute and ask a question. Man, you got the man here. Dr. Bax is gonna. There has to be a question.
I have a question if nobody else does. Oh, Dr. Hale, do you have a question?
Can y'all hear me okay?
Yeah, awesome.
I had like 45 questions, and then now that I'm under pressure, I can't remember any of them. But one of the things that that you talked about,
You're Alice.
oh gosh, talking about the inflammatory markers. I've heard of someone from AOSH had mentioned that the CRP, that hygienists can test the CRP chair side. And that sometimes if the inflammatory markers are too elevated, if we treat like for therapy and stuff that same day, we could create more inflammation. So there was some concern there, but I don't know if this is the right place to talk about that or
No,
not.
and so this is about 3 or 4 years ago, because I'm always looking how to incorporate this with the people that I know. And there was a chair side test.
Mhm.
I don't know if that's available anymore. I mean, I think there was an attempt at a chair side test, but that's a great question. So Dr. Bax, if a patient was undergoing, let's say that they were undergoing some periodontal treatment, currently, would that have an effect on a lab?
Probably not that quickly that particular day. In other words, it'd be interesting to do it before and then
Yeah.
after. No.
Yeah.
But these kind of studies don't exist. I think, once again, it's taking these tests, it's important to look at the context. And I would also say more critical than the absolute number is the trend. So if you have an elevated C-reactive protein, but you're otherwise seemingly well, and it just stays at that same level all the time, that's less relevant, I believe, than if you see a sudden increase from a baseline or a decrease from an elevation. It tells you more than the absolute number. So I think a lot of these tests are sold by test providers, as I hate to say it, almost like a gimmick, but and maybe some people would look at this ultrasound opportunity as a gimmick as well. But we have a growing number of patients who, I had no idea, how do I get rid of this? And it just gives them the opportunity. Not everybody's going to, react to that opportunity, but boy, if you can, show somebody their future by looking, by just taking a couple of minutes and using harmless ultrasound, and get them to, and the side effects of all this, I keep telling the patients, all of our side effects are good. You lose weight, you have more energy, sleep better, you have better teeth, all these things. We're not talking about these multitude of side effects that you hear listed out with so many of the pharmaceuticals, especially the newer ones.
So Alice, you brought up a great question that makes me think of something. Okay, so let's do a hypothetical, and let's say that time wasn't an issue. Well, we know time's an issue, and let's say that money wasn't an issue. Time and money are not issues. Dr. Bax, what tests, okay, could we do in the dental office as a preliminary screening, on a consistent basis? Okay, so right now we do blood pressures. Okay, could we potentially, you can do A1Cs. I mean, there's a machine you can do point of care A1Cs. You could do that, and then you could do your butterfly screening. Okay, is that a potential package that an advanced hygienist could do? Can you think of anything else?
Well, I like to look at things. I like to encourage us to do things that aren't otherwise being done. So
Okay.
A1C, blood pressures, they're being done so many different places. But I mean, one of the, and I know this is sound self-promoting, but looking this ultrasound, it's just not being offered.
Right.
And ideally, if you could do if you had a sonographer who could do a CIMT on everybody, and they would, that would be affordable. That if money were no object and time were no object, I'd say the CIMT is clearly gives you more information. And and Dr. Bale and I have gone back and forth, and Amy, to some extent, it's like, okay, what if you miss? There are some weaknesses in this. You may miss some soft plaque, and if the sonographer isn't careful about spending enough time to give good images, we can meet some. But our fallback is always, what? I'm a little uncomfortable giving you a clean bill of health based on this image. Come back in 6 months and do it again, and let's see if we get better pictures, and so forth. A lot of it is built into the process. But I think, quite frankly, salivary diagnostics may be more helpful than any of these things, because if you're walking around with PG or AA in your mouth, I mean, it's not just cardiovascular disease, it's dementia, it's high risk pregnancy, it's autoimmune disease. I mean, all these things have been associated. So, I mean, I always say that it's really important that we, as teammates, we all play our position to the best of our ability and not everybody else's. So you don't want me doing, drilling and and treating caries. So I'd leave that to the experts. That's why that's how we play to each other's strength. But the key thing is, the reason I created the Cure Coach platform is so that we're all singing from the same set of facts, on the same page. And for those of you Barb McClatchy and Eric Golder, I mean, it's great. They practice side by side in the same building under the same roof.
Right.
But, most of us are not going to, marry our spouse based on whether, I'm a doctor and she's a dentist or vice versa. We're going to have to find some other way to date, if you will, in order to, work together and scale this. And to me, this is all about having, if a solution isn't scalable, it's not going to have much impact. But heavens to Betsy, we have such an urgent need to deal with cardiovascular disease. And it's frankly, to me, for standard, and I'm going to put this out there, for mainstream healthcare, I stopped calling it mainstream healthcare. It's become fake healthcare. It's not doctors thinking through a patient's problems and what's best for them. It's just following a set of orders and protocols. And frankly, the system is failing, and more people are dying suddenly, suffering strokes. We won't get into some of the controversies about what's causing that, but the point is, there is an opportunity that if you know that you have arterial disease, at least you have an opportunity to do something about it. You can educate yourself, learn more, and even if you don't see a BaleDoneen provider, you can read the book, you can eat less sugar and carbohydrates, and do some healthier things for yourself and help. But the point is that dentistry, hygiene sit at an opportunity. You see these people so often, you can become the primary care home. And the other argument that I would make is that until you all have figured out how to do virtual, hygiene visits and procedures, the natural place for these other things that require hands-on evaluation, the CIMT and the like, is in the dental practice. And it can be good. It'll be good for the patients, but I would say it also stands a good chance to be good for the dental practice too. One dentist I asked, "Why do you do this?" He says, "Well, I never had a dead patient or somebody who was disabled in a nursing home want full mouth reconstruction for cosmetics, for instance." So the point is, keep your patients well and alive that come back and, see you for years.
We've got a couple questions in the chat. Dr. Fromm, do you want to say your question, read your question out loud, or do you want me to? I'll do it.
Okay.
Oh, I can. Okay. So he says that they are, I don't know if you're a boy or girl, sorry. They say that there's a variety of portable devices that can measure antioxidant profiles, nitric oxide profiles, CRP profiles. PubMed shows reliability and issue. Are there any devices other than the Butterfly that you recommend? And we have another question after that. So when you answer that one, I'll answer the next one.
Well, there are a variety of ultrasound devices that each have their advantages and disadvantages. Some are wireless and send an image via Wi-Fi to the device. But as I've done the GE, I've done Sonon, and this is the lowest cost, most versatile, most highly featured platform that I've run across. And I don't get a commission for, promoting this particular device, but although I work in partnership. And I did see in the chat, if anybody is interested in learning more details, just, text my cell phone number or email me and we'll set up a time to chat, what I call a discovery call. That's probably the best way to address that.
So let me ask you a question, Dr. Bax, because nitric oxide, that's another thing around mouth rinses, and I'm trying to become educated about that in particular. You can do a saliva test for nitric oxide, but and there are nitric oxide supplements and super beats and all kinds of stuff, because I'm taking some of that stuff. Talk to me teach me something about nitric oxide.
Well, nitric oxide, and I'm no expert on it by any means, but it is a substance that it's a vasodilator. So, it improves blood flow to a variety of, so it's about improving blood flow. But I think we have to be careful when just because an agent that's active in the pathway biochemically in a process, that if we measure in the saliva or the blood at any given moment, that it tells us anything at all, or supplementing it does anything at all to change, what really matters in that is blood flow, because there are so many other factors that go into blood flow, presence of plaque and other agents that are participating in that process, inflammation, et cetera. So I think it's very tempting to, somebody's always trying to sell some, agent that does this or the other, but it's really the whole overall picture that one is really going to see the benefit from addressing. So, is it good to have more nitric oxide in your blood vessel wall if you're trying to get more blood flow? Yes. Can you really predict anything about that from a given supplement or a measurement? I'm not so convinced.
Okay.
There's another question here. How can we improve interprofessional collaboration with physicians is the first question. And then the second one is with the same person. How long do you recommend hygienists wait to see patients for a cleaning after they've had a heart attack or a stroke?
Great question. Great question.
I'll take the second one first. I mean, I would say, there's a good chance that failed hygiene is responsible or contributing to their heart attack or a stroke. So I'd say get them in there as soon as possible to stop the next one, for heaven's sake. So I don't know why you would even consider waiting to be. Maybe there's something I'm missing in the question.
There's a lot of, we were shut down during COVID. We're not part of the body.
Right. And you have to wonder whether, how many of those people came back after COVID with really great looking gums and very little plaque, right?
You have to understand, Dr. Bax, you probably don't know all of these old crazy, things that are still out there about pre-medication for antibiotics. Okay. To have your teeth clean, so there are a lot of real old paradigms that are still, and that's one of them too. Like, well, we can't touch you. You just had a heart attack. It's like, at the very least, have them in and do a pathogen test and, see their AAs and PGs up here. It's like, oh, okay, that was a contributory factor, right? So,
and there's many physicians that still say that. There's a lot. There's a lot of physicians that are saying that to the dental industry, like, oh, I don't want you to go in. I've had, when I was practicing full time, I had many patients that were going through chemo and radiation and all kinds of different cancer therapies, and their doctor didn't want them to go in before these intensive treatments. And I'm thinking that is the absolute opposite thing, that this is going to have a counter effect.
Yeah, I would say get another opinion. There's a saying in medicine that progress occurs one funeral at a time, and what they mean is that it's the disappearance from the stage of the thought leaders. So that new paradigms and new thinking can take over. It takes 15 years minimum for new information to make it into medical practice. So we're very tradition oriented. And it's only gotten worse with pharmaceutical industry capture and increased employment of physicians and other providers, employed physicians. I'm sorry, I was employed at one time. I'm independent, and it's just a night. It's only gotten worse. If you don't toe the party line, if you don't do what the protocols say, you risk losing your job. And it's not just around COVID and it's so many other things. You're expected to check the boxes. I'm sorry, it's just it's a very disappointing thing about our healthcare system. It can't, and I'm convinced it won't be fixed. It has to be replaced.
The second part to that question, Dr. Bax, was, do you have any thoughts on how we can better improve the interprofessional collaboration with physicians?
I'm going to put in a plug for the BaleDoneen preceptorship, or at least, read their books and get more curious. And, I think attend Tom's, meeting and I think, organizations like AIOSH would have the potential to bring dentists and physicians together, but it's very out of balance, in my opinion. It's like 8 medical doctors and thousands of, or several, 1,000 dentists. It's just, we have to start the conversation, and events like this, I think, are certainly a start. We just need to do it more and more often and make it possible. And to put in a plug for our Cure Coach platform, it provides an opportunity for us at least each to see the information and to communicate within that platform. I think one of the biggest barriers to working together is the friction of the traditional, well, I'm going to call your dentist and talk to them, and then we're going to play telephone tag for 3 or 4 days, and then we'll finally talk, what was it we were going to talk about? There's so much, we need to eliminate those barriers to collaboration. And that's been my passion for the last 3 or 4 years in developing our platform.
Yeah, and I would say just hang around, find like-minded people. Like this group has been amazing. It's kind of organic from, so this will be our 3rd event that we're having. And I think Tasha and I would say we've seen the evolution. Each time we're bringing, like Dr. Bax was new last time. We're bringing in a microbiologist this next meeting. It's evolving, okay? I look at this as a giant puzzle with a lot of pieces. And, I'm just trying to assemble these pieces together. And so, but one of the things I would say that's different about what Tasha and I are doing is that I'm kind of dedicated to clinical stuff. I don't want to sell, I really don't want to sell the oral. If you need to be convinced that there's an oral systemic connection, you kind of need to go some other course. I don't want to sell that, to me, that's a given. But I want to do is to give you tools and techniques, and clinically, I have to show you how to make a living. Okay, if you can't make a living, and that's why prevention's never really caught on with any vigor, is because people haven't figured out how to make a living with it. Well, the BaleDoneen docs have, people are searching for a higher quality of care. If we can teach dentists and hygienists how to provide a higher quality of care and connect them with the patients, I think that's the win. In
addition to that, I think the collaboration, as well with the advanced dental clearance and working with Beam readers and their portal. I don't know if you want to share anything about how you can.
Yeah, so that's kind of my ultimate goal, because when someone is interested in the microscope, I start and say, I'll take you as far as you want to go. Meaning, if you just want to do a better job in convincing people to get periodontal treatment and that's it, great, I'll do that. If you want to bring a physician physically into your practice and work side by side, great, we'll go all the way there. There's kind of a broad spectrum with that. And so the concept of advanced dental screening was, I started looking at what a dental screening is, and a dental screening is a joke. If a surgeon sends you something and says, I need you to sign off, I've got a slide in one of my presentations where I took a screenshot of the questions in a dental screening, and it's just it's meaningless. What a surgeon, what a physician, what anybody's looking for is, does this person have an active infection that's going to compromise my joint replacement? Is this going to compromise my aortic valve replacement? Do they have active pathogens in their bloodstream? And people are putting, everything looks fine. It's that's not a screening. I mean, it's crazy. So what we're doing is really elevating the bar and saying, okay, let's do a biofilm DNA test. Let's look at the pathogens. Let's do a real basic sleep screening to see if you have some elements of that. And then the CT scan, and one of the reasons why I'm happy that we're having it read by a radiologist is that I kind of would like that standardized. I don't want to get a variable of the dentist interpreting that. So and then Beam Readers is providing the platform to share the information. So I'm anxious to do that. And that's just an added value to everybody that we train, for them to take that and use it as you want, to reach out to BaleDoneen physicians, MD, VIP guys, and whatever. So yeah, that's kind of the idea behind that.
Yeah, I think the great thing with being able to share that information is, you can upload any of these, any lab test that a dentist would have, that a physician would have, and then you can share it with as many other professionals as you would like. So
Right.
if there was 3 different dentists on a case because it was an advanced implant case, and maybe the patient had severe diabetes, you could collaborate with their endocrinologist and everything could be uploaded to this portal. And I think when we have more tools like that people are used to, it's gonna make collaboration so much easier.
Yeah.
Versus waiting for those phone calls.
Yeah, for sure. So I saw a chat because it pops up and goes out. Hillary, somebody is from Dubai.
Yeah,
Hillary needs to reach out to me immediately. I want to go to Dubai. Tom@tomlarkin.com. Please reach out to me.
Hillary was also wondering about nitrous oxide supplements, that if there were any that you recommended, Dr. Bax.
I'm going to take a pass on that. I'm not an expert on that. It's not in my usual armamentarium. Do they do any harm? Unlikely. I don't know that it's not addressing a specific root cause of the disease that I pay closest attention to.
All right, Hillary, I'm waiting to hear from you. I just saw your message. Reach out.
I think the main reason that nitric oxide gets so much attention is that it's the primary mechanism of action of drugs like Viagra and Cialis. So
yeah. So Hillary, one thing I need to say to Hillary is that my next door neighbor, I live in Lexington, my next door neighbor is Sheikh Mohammed Al Maktoum, the ruler of Dubai. Okay, he's my next door neighbor. I live next to his farm, so that's why I want to come visit.
She's sending you an airplane right now, she said.
Awesome.
nice neighbors.
Yeah, you'll see when you go here. Yeah. Any other questions?
I think that sums it up.
Okay. All right. So if there are no more questions, I want to thank everybody for this opportunity. And I just wanted to do something kind of unique and kind of walk through what it was like to be a patient over 10 years. Dr. Back's been a BaleDoneen provider for 10 years, and kind of make this more real. Okay. Because it's obviously very real to me. And I'm very grateful to Dr. BaleDoneen for kind of putting me on a track and kind of put us all on the track. I mean, there are a lot of like-minded people here, and our meeting is attracting, really interesting. And Tasha, you would agree, we're attracting interesting people, really purpose-driven people. And
So
Dr.
many
Hill,
incredible people, so many.
I'm just going to put in a plug. I think I've been to a number of such meetings, and it really is the most practical and pragmatic, and leads to action as opposed to just talk.
And that's really what I wanted to, and I thank you for saying that, because you can talk about things, but until you actually give people a tool and give them a direction, the conversation gets lost. And I think that's why the oral systemic conversation has kind of it's just bounced around for a decade. And that's why, I don't want to get involved in this unless I have to be able to move the needle, improve practices, improve everything that we touch. Right. So I'm flattered to get the opportunity.
Me too.
Yeah. Awesome. So anybody, if you want to reach out, you got the contact information, Dr. Bax and myself and Tasha, and we're going to
this recording is going to be available.
Yeah, we'll make it available. I'm not exactly sure where, but yeah, we will definitely plug it in, because I've already had some people that couldn't make it tonight that definitely wanted to see the replay. So we'll be doing that. And then I think our my next topic, what I'm trying to do is kind of go through some of the topics that we're doing in our course. Our next topic is going to be ozonated water, which is really a cool topic, and people have lots of questions about what's going on there. And we're going to talk about that at our next meeting. So very good. Tasha? Thank
Tom,
you.
I want to tell
Yes.
you something about ozone. So
Okay.
my son's a wrestler, and so I have ozone and all that. But he has subsequently caught a staph infection from ringworm that he was clearing up, but now it's staph. So I'm ozonating the I don't know what you call them, the lesions.
Right.
He's got them on the side of his, and like last night I ozonated a few little blisters that were coming up, and they like cleared up overnight. It was amazing. I was like,
Wow.
oh yeah.
Yeah.
My
No,
little
just-
plug
Yeah,
for
no, I've
ozone.
heard, I think it's an amazing technology that's yet to be fully utilized by, especially by dentists, all the stuff that we do. For
Yeah.
sure. Cool. Very good. All right, Tasha, I'll let you end recording and